They have concerns that there was a severe pulmonary contusion too. They want to evaluate that part and also evaluate if there was any spinal or rib fractures because that really changed the whole thing. The cat was already pre-oxygenated, so we have 2 minutes to take X. So with the digital X-ray, you can do that really fast. So uh, we discuss it with the client, we tell what we found, and this is something that really encourage you guys. You need to talk with the owner. The owner needs to be aware what's going on because especially cats owner are really, really sensitive about. So we talk about this, establish priorities. We say we're gonna decompress your cat. So we did thoracocentesis and remove with a simple butterfly 110 ml blood each hemithorax. That's an enormous amount. So cats cannot lose that amount. We speed up the fluid therapy a little more aggressive. And we start working with this blood. We went to those filter, the one down there on the right. It's a very simple filter that you put in one extreme, and we infuse this back through the IV catheter. So we provide filter auto transfusion to the cat. That really, really helped. We reduce the respiratory stress, blood pressure start getting more normal. We reach at the some point 93 millimeters of mercury as a systolic blood pressure. It's not perfect, but it's much better than it was. And lactate, who was around 5.5, who is very high, went down to 4.8. Again, that is not normal, but it's much better than it was. So we were very happy with this. However, clearly improving Amanda, 2 hours later, everything started getting bad again. Respiratory distress increased. We repeat the ultrasound, and this is what we saw. Again, you can see the heart, and you can see again a large amount of fluid accumulated in the pleural space. Down there, there's an X-ray to check if we didn't miss anything. And here we go again, talking to the owner and say, listen, we can put a chest tube or we can go to surgery. The chest tube is the decompression, and we have to give transfusion or provide at least a good amount of fluid and probably some frozen plasma. But this is very serious. If you keep bleeding, no matter what you do, this is a cycle. You pull the blood from the chest, you put it inside the cat, and it just keeps bleeding. You're gonna have again pleural effusion, hemothorax, and here you go again. So the client was really, really confused. They didn't know what to do. So a few minutes later, she come back and request euthanasia. And when we talk about the euthanasia, we normally discuss why, if you're sure, etc. And the combination classic is cost, suffering, and bad prognosis. The combination of those factors ended up with Amanda being euthanized. So remember that I told you no happy endings in this story. So you have any question, please, at the end of the presentation, I'll be happy to present, to try to answer questions, as you said. So I think everything is doing fine. Okay, cool. What a beautiful. These are photos from the awards of the National Geographic. They're fantastic. It's really, really impressive what they can get. So the next case is different. This is Clover. Clover is a dog, as you say, is a male neuter, 9.5 years old, French bulldog. Healthy, no clinical symptoms. The dog have preventive care today, nothing weird. Family normally work all day. The dog remained in the house for a lot of hours. This was obviously before COVID, before the pandemic. So the family went home, to work. The youngest people went to school. And when they come back from work, they found Clover unconscious. And they don't know what happened. The other dog in the house was perfectly fine, a little Yorkie. So they do not suspect trauma. There were no sign of trauma. The dog was exactly where he's supposed to be, but unconscious. We start asking always this by the phone if there's any human medications available. No, nobody is under treatment with chemotherapies or antidepressant or psychotropic drugs. The no other pets who can hurt him, like large dogs. No, they left at 8 a.m. and they come back at 5 p.m. So we have quite 9 hours in the middle. So a lot of things. Their routine is normal. They do this all the time. Nothing is different. However, Clover in the hospital had a seizure in the way to the hospital. He's very lethargic, but occasionally awake. When he arrived in a stupor, so what we call semi-coma. Heart rate is within normal limit. Respiratory rate is low. He is breathing 5 to 10 times per minute. He have myotic pupils. So again, we suspect this could be some sort of intoxication. We reinterrogate the family. He's hypothermic, 35.5. Blood pressure is between normal and elevated with a 123 systolic, who is okay. We expect that blood pressure a little bit lower, but dogs never read the books. Pulse was not palpable, and it was like, that was like, okay, something is going on. Remember this: pulse is strong when the difference between systolic and diastolic is large. If systolic and diastolic pressures are close by one each other, the pulse is going to be weak, no matter what is the numbers. Okay, so pulse just reflect the difference between systolic and diastolic. We were in this evaluation, everybody moving, nurses working, taking the first samples, preparing the area, putting some catheters, bringing oxygen, blah, blah, blah. And the daughter's boyfriend seems to be suspicious of something, and he decided to talk, and they say, well, we talk about this, everybody looking at him, and then we realized this. The young guy brought this, and then I have to make a little parenthesis. Oregon, the state where I live, is one of the states that legalize marijuana. It's legal here. So that implied a bunch of business about marijuana, not only marijuana as a recreative drug, but also about edibles, about the most incredible different sources, oils, concentrate, for medical uses and for recreational usage. This one is recreational. It's a pouch of dark chocolate who contain a large amount of CBD, who is the recreational part of the marijuana. This contain a pouch, contain 10 mini pouch, and has the problem with this. And they found it, and it looked like Clover eat it all. So when you read the information in the bag, it said contain 10 milligrams of THC and 10 milligrams of CBD. One is the recreational, one is the non-recreational effect of the marijuana, but also contain dark chocolate. And that particular bag contained 20 pieces. The chocolate they used to produce this edible is 72% cocoa. So it's very concentrated and it's very pure. If you read the back, in the bottom part of the bag say, until you know the effect of this product, eat only half a segment and wait at least an hour and a half before taking another one. Well, Clover ate 20, who means a gigantic level of intoxication. The problem for us was, okay, is this about the chocolate or this is about the marijuana? And when you put that, this is the way we found Clover. At this is one of the ones moment. The monitor showing everything looks so fine. Blood pressure is normal. Heart rate is a little high, fast. Saturation is normal. If you see the curve there of place demography, she seems to be breathing kind of rapid. So not bad. The respiratory rate is around 95. The mean blood pressure is 95, with a respiratory rate around 70. So temperature is 101.7. Everything looks like it's doing good. However, When you analyze what happened in a combinatory between chocolate and marijuana, chocolate, the toxin is theobromine, is absorbed very rapidly in less than 1 hour. The lethal dose is 50 milligrams per kilogram. We calculate that clover get like 220 milligrams per kilo. The symptoms are tremors, tachycardia, hyperthermia, hypotension, seizures, and in severe cases, arrhythmias and death. When you go for the marijuana part, the toxin is tetrahydrocannabinol, is THC. The lethal dose is variable, seems to have individual sensitivity. The absorption is also rapid, very rapid, like in 1 hour, especially in edibles. The symptoms are incoordination, ataxia. We all have that friend who like marijuana. PUPD, those guys normally drink a lot of water and pee a lot. Bradycardia, seizures, coma, and death. So the symptoms, the external signs, seems to be very similar. So we were like, okay, where we go with this? It was very late for us to try to decontaminate the stomach. And remember this, if you want to decontaminate, you have to have a conscious patient. You cannot decontaminate or make a vomit a dog who have conscious issues. And that was the case of Clover. Clover was very, very anxious to very, very depressed to very, very hyper to very, very depressed. So it was up and down, up and down. Uh, so an analysis, we start with CBC, chem, light, and gases. We start IV fluids where normal are at 15 mLs per kilo per hour. A little more, we're trying to flash this. But Clover started becoming very unstable. We use midazolam, recognize those 0.5 mg per kilo IV during severe tremors or seizing. Clover start having seizures or tremors, so we use midazolam or propofol. But as soon as we start controlling seizures, he gets really, really depressed, lethargic, and go respiratory rate goes down, hypotensive goes down. So we have this roller coaster of up, very, very lethargic, followed by dysphoria, seizures, tremors. We treat it, and boom, he goes down again, lethargic, severe depressed. So we ask ourselves, what are the signs due to chocolate or marijuana or both? We assume it's both. Somebody put on the table using phenobarbital to control seizures in a more effective way. The decision was not, because essentially you have to load a specific amount of phenobarbital to make it that, and we don't know what Clover is going to do with that. With those depression in the middles, we were scared. The same happened with Keppra. I don't know if you guys in Europe have Keppra available. It's levetiracetam. It seems to be very safe, but we have a report of one death case here, so everybody step back like, whoop, what was not that safe. So we decide to put it under anesthesia, what we call an induced coma. So we hook it up to the machine and start ventilated and with isoflurane. The dog do not need mechanical ventilation because it was breathing, not very regular, but it was breathing. So we give it just with isoflurane. So under anesthesia now, Clover moved from tachycardias of 250 to bradycardias of 20 with no intervention. So when you're about to treat the tachycardia with maybe some atropine or glycopyrrolate, the heart rate goes up to 200. It keeps going up and down. The blood pressure tends to be more in the hypotensive range with systolic around 80. The respiratory rate also have huge variation from 90 to 6. So we keep it in this one, we keep flashing. The whole family is crying in the waiting room. And 3 hours later, Clover decided to go into respiratory arrest and he stopped breathing. So we ran to talk with the clients. We already discussed CPR, but circumstances, the only option we have is, can I ventilate it? I need to hook it up to the mechanical ventilation. The clients and the class, but I don't know what to do. How much is this? Mechanical ventilation is, I would say, between $1,200 to $1,500 per day. So it's a big deal. So it's a lot of money. So in other discussions, have to step in. Listen, Clover is dying. Do I or do I not connect it to the ventilator? Blah, blah, blah. Okay, do it. And they approve it. Mechanical ventilation. We hook it up. We set up with a respiratory rate of 15 per minute with a volume of 10 mLs, 10 mLs per kilo minute, with a PEEP or positive expiratory pressure of 10 centimeters of water, who is kind of very common. This dog do not have a respiratory problem. It's just not breathing. So we keep it with that. We agree that it's going to be only for 12, 14 hours. They cannot afford anymore. Uh, we never heard about the boyfriend again after this. I think he was killed and he's floating somewhere in some river there. But the agreement was this: we're gonna put together the family and the team tomorrow. Clover spent the night overnight with us and the ventilation with no serious changes. There's a less severe variation, but still. So they know if we're gonna disconnect the Clover from the ventilator the next day and he's not breathing, essentially we have to euthanize. And they agree with that. They show. We wake him up and Clover wake up and is breathing by himself. The ECG shows normal sinus rhythm. After waking up, he is quiet, alert, and responsive. The neuro exam seems normal. He starts showing sign of appetite. My nurses offer food. He's interested in food. He starts waking up, moving like, good morning, everybody. What's going on? So there's no evidence side effects. We repeat tested. Family is happy, happy. We repeat CBC, chem lights and gases, and everything come back normal. So this is our face, like what? And this is Clover. So what is the uh, story behind this? Do not take decisions before the time. Dogs and cats do not read the books. So Clover went home with zero side effects, no sequela, and he still is a happy dog. He's an old dog, but a happy dog. The boyfriend, we never found the body. So just let you know, okay? So I don't know what is the situation of marijuana, particularly in Europe. I know in some countries it's approved to use, but we seen this, and believe me, if the commercial part of marijuana is open in Europe, you're gonna see a bunch of things. There is marijuana availability here in presentations that I never imagined. There's tampons with marijuana here. There's little gummies with marijuana. There is whatever you can imagine with marijuana. There you go. So let's go. Again, National Geographic photos awarded for the year. Hope you liked that. Okay, let me show you Lucia. Lucia is a feline calico that is 6 years old, and like all the calicos in the world, she's fractious. That's mean I'm gonna let you do whatever I want, nothing else. So most of the time means for whatever you need to do, you have to sedate her. Lucia has very short fuse about what she can tolerate and what she cannot tolerate. So uh, Lucia was scheduled for surgery and the for a mass removal in one leg. The whole story I was not aware, but the doctor in the case suspect that it could be a sarcoma because it's an injection site. Decided they did biopsy, I mean aspiration, cytology. The cytology come back malignant. So surgeon prepared for the surgery, mass removal, aggressive, etc. And he went for the classic process. Anesthesia is the standard inhalatory gases. Pre-surgical exam were all normal. Physical exam, CBC, chemistry, UA normal. It's a routine procedure. Nothing happened, and she goes home with oral mucosa buprenorphine, who is has analgesia, and they send them with clindamycin suspension, 1 ml twice a day for 5 days. Classic. Everything was normal. So this is Lucia, beautiful, of course. Lucia come back to the hospital after 48 hours. The owners report that we're panting. Uh, he think that the house is too hot, so she turned on the air conditioner in the house. However, Lucia keep breathing pretty bad with the abnormal breathing, so they went to the hospital, and we get Lucia back to the hospital. And this is Lucia, the way. Check how she breathes. It's very subtle, but check the movement. A cat should not be doing that. It was okay. Give it a second look. Again, check the belly. She's moving the abdomen and is using the nostrils. Okay, so mild, not severe, but we found that okay, what we're gonna do now. So the respiratory frequency is 100, shallow, fast breathing, occasionally open the mouth. The cat is bright, alert, responsive, so she looks very there. And there is a little bit open the mouth. We found there is a little painful in the abdomen. Mucous membrane a little pallid, but pale, but it's a cat, so that's not a big deal in cats. The heart rate is 110, pulse is firm. The auscultation is a little dull, so I cannot hear very much the respiratory sounds, the chest sounds, and there is a little bit of abnormal sounds that describe it as cracking. So we follow our regulation for triage, and we put in T-FAST. T-FAST is the ultrasound thoracic for this. It's simple, it's not aggressive, we don't do anything, and this is what you normally see on T-FAST. Remember, right here, let me show this. Let me get the pointer so it's more visible. You see this? This should be moving. This is the pleural space. What you see going and coming is what we call slide, is the movement of the parietal pleura over the visceral pleura. So the one in the chest against one on the lungs. They move one over the other one, and this is what you see. Again, in another view, this is the normal part. This is not moving. And this is what you want. You want that part moving on the right, but the one on the left is not moving. And when you don't move it, you don't have a slide. That is a pretty consistent finding with pneumothorax. So we suspect it's pneumothorax. Immediately, the cat is stable, so radiograph. And let me show you the radiograph. Whoa. This is kind of ugly. I'm gonna let you know what you find here, but if you see all the areas with extra air, you're gonna find there's air here, air here, air in the center. This is also gas, and this is also air. You want the other view? Okay, that is a BD. Confirming a little bit more the mass, and we say, wow, what happened here? And the diagnosis, the radiologist diagnosis is super simple. You guys have pneumothorax, pneumomediastinum, pneumoretroperitoneum, and pneumoperitoneum. What most likely is a tracheal rupture. So Lucia, there's two hard things. What we do with Lucia, and who's going to talk with the owner and explain it. You know what? Remember that we told you everything's going to be fine? Well, it's not. So we put it in oxygen, regulated at 40% VO2, start with a very simple fluid, 15 mLs per hour per cat, not per kilo, mainly to have venous access. We want vascular access, so we keep it with that. Sedation, we use butorphanol. And for analgesia, we use a combination of dexdomitor with buprenorphine, very low dose of both. We don't see she's in a lot of pain, but definitely the distension of the abdomen can produce some degree of abdominal pain. We tried to do thoracocentesis to remove the air from pleural space, but Lucia, like a good calico cat, say, nope, you're not gonna do this to me. It hurts, so stay away. She started getting stressed out, and remember the rule: you don't want to stress a respiratory cat. That is a pretty bad idea. We talk about the possibility of putting a thoracic tube, and I'm gonna put another subject on the table. How many of you will charge for this? How many of you will talk to the owner and say, yeah, remember that we did this? Now you have to pay for all this. And in human medicine, there's no question that you have to pay if something still happen. In veterinary medicine, this guiltiness take control a lot of doctors around, and they don't want to charge because they feel it's my fault, and oh, she can sue me, and they're gonna have lawyers, etc. We charge. We try to be empathetic, but it's medicine. It's not mechanic. So 2 + 2 is not always 4 in medicine. So we discussed about putting the thoracic tube. That idea was postponed, I would say, because she seems to be very stable. So finally, thoracic tube again. We put a thoracic tube with intermittent vacuum, negative pressure. The idea is try to remove it. And of course, 24 hours later, you can see it's much better. No, it's not. Uh, it's not much better. It's actually seems to be even a little bit worse on the pneumothorax and the pneumoretroperitoneum. So here we are, still accumulating air in spaces that it should not be. This is the VD again. Definitely not getting better, getting worse. And conversations, what we're gonna do about it now. The client is really upset, is demanding actions, that this is no fair, why this is going on, who is responsible, blah, 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 blah. So no improvement, is getting worse. However, Lucia seems very stable. Despite all this and the horrible ultrasound and the horrible radiograph, Lucia seems stable. She's not really interested in food, not eating a lot, but she doesn't seem to be very, very, very stressed out. She looks very comfortable breathing with oxygen. So we keep it hospitalized. It pulse ox is around 89, 91%. That is not a zero. It's 89 to 91%. That is not good, but it's not horrible. We keep with IV fluids, systolic pressure. Our goal is around 85 as a systolic. We keep playing with sedation and analgesia. Obviously, we have to add an antibiotic here. We use orvafloxacin, who is simple. And we use acetylcysteine as an antioxidant, as a scavenger. And conversation, yes, no, we decide to repair the trachea. The question is, how the heck we're gonna know where the trachea is ruptured? That is not easy to see. At this point, there's subcutaneous emphysema too, if you see the radiograph. So there's no other option than put it under anesthesia and go with a tracheoscopy. Here you go, everything. Oh, I think I know where it's ruptured. So, okay, you mark with the light externally, you can see the light. So you mark where's the area rupture. You keep going though all the way down to the carina, the separation of bronchi, to see if there's no other ruptures. And okay, they seems to be okay. That's the carina, the separation of main bronchial. We go back, nothing else to do. We're gonna reduce that. The surgeon already know where is the rupture, who seems to be pretty nasty. And we'll move it away. Get out of the trachea, please. Yes, get out, and here we go. So mission accomplished. We know what it is. Then the next step of Lucia, repair the injury, repair the trachea. Apparently, technically, it's not really complicated. So a little bit of debridement, repair. The whole idea is try to repair the airway without any leaks. So that was done. All cool. Lucia dies during the post-surgical recovery. She went into a collapse, cardiorespiratory arrest, and that's it. You can imagine what that means in a hospital, no? Everybody's super confused. Who's going to tell the owner, the anesthesiologist, the technicians, everybody trying to figure it out if they can see you or not. Who's going to talk to the owner? And well, you have to do it. And the main point is, are we guilty? We did something wrong. The technician who intubated is a very experienced technician, is a certified. So we have to investigate to discuss this. That is my recommendation. Every time you have to put a situation on the table, grab some information and see if this is something that you did something wrong, because essentially you can make something wrong. What the people do not tolerate is that you don't care. So if you say sorry, something happened, something went wrong, etc. So we investigate, and this is what we found. One of the point is we should have done the surgery before, and the answer is not. The majority of the tracheal ruptures should be managed conservatively, and the prognosis is much better when you manage like what we did. And we're looking for what is the cause. The large majority of cases in cats is cats who are intubated. One of the causes who has been identified is when the tube is rotated after the cuff is inflated. So you put the tube, you inflate the cuff, and you move the cat without de-inflating the tracheal tube. But we found a large amount of cases that have no explanation. So this could be one of those. We don't know what it did. The nurse did everything that it's supposed to do. So here we go. Management has to get an agreement with the client who was still hating us, but it's understanding. I mean, you have to understand that she have all the right to be very upset, especially for people who have no medical background. They don't understand. I brought my cat for something, and you kill him. That's the no. Sorry, we don't kill him. She died in a medical procedure, and we are really sorry. That is very important, that they feel you care and you feel very sorry about it, because you have to. It's a life, and don't feel bad about it. Again, in emergencies, this happen very common. Okay, so again, National Geographic. This is so beautiful, so beautiful. We have a lot of those eagles here in where I live, golden eagles, and I have to say they're very impressive birds. They're huge, and in this area, they normally live very close to water bodies like lakes or little ponds, and they have the nest very, very high on Douglas fir trees, kind of like pine trees, and you can see the baby birds in certain time of the year, normally during the summer. They're beautiful, beautiful, beautiful. Okay, let's move on. If there's any question, remember, at the end, we're going to do that. Let me show you Muna. Muna is a beautiful 5 years old female spay boxer. I love boxers. I don't know. I always like. She have everything normal: preventive care update, vaccinated, deworming, etc. Nothing really relevant in the history. And she showed up because she's having hemorrhagic diarrhea for 3 days. So still normal appetite. She's bright, alert, responsive. No dehydration found, just the diarrhea. So internal medicine work. I don't know exactly what they did, but they tell them this is very likely an IBD, who is an inflammatory bowel disease or colitis. They classify the diarrhea as a large bowel. So they send it with metronidazole, 10 mg per kilo twice a day, Pedialyte oral to provide some oral rehydration, probiotics. Everybody giving probiotics now, once a day for 2 weeks. Counting pectin, who is a kind of like mucosa protector, and we send it with diet. In this case, with ID, who is a Hills diet, canned food, really good. That's what we normally use for gastrointestinal follow-ups, and We prefer canned food than dry food because we sure know that dogs prefer canned food. So we want to be sure that she want to eat it. So we send her home and we expect nothing back. But after 1 week, Muna is back. Owners said she was fine for 2 days, but again, is back with hemorrhagic diarrhea. But now she's sick. She don't want to eat. Is anorexic. She tried the classic thing that owners try, like they try the canned food, then she tried the chicken, the rice, the soup, whatever. Uh, uh, Also, Muna, according to the owners, that is ATO, according to the owner, is lethargic, and she said that the level of energy is around 30%. We estimate that dehydration is not really severe. The estimation is around 8%. So everything fine. We start working now. The big difference for me, the point of view of the emergency is now we have a sick pet. Diarrhea is very common, vomiting is very common. So to me, the difference is if you forget about the diarrhea and the vomiting, is your dog also sick? Look sick, behave sick, or no? Everything is fine except when she pooped diarrhea, like the flaca. So our approach is classic physical exam. The diagnostics are CBC Chem lights. We run CPL, who is lipase canine, pancreatic lipase, who is essentially for pancreatitis, negative. Always, always, everybody, especially my nurses, always want to run parvo. We see very, very, very occasional cases of parvo in Oregon, and the cases of parvo we see normally came from California. So here, parvo is very rare. So it's negative. Fecal, looking for parasites. If this is Giardia or another worms like roundworms, etc. Negative. There's no eggs, no parasite. So the intern take an X-rays of the abdomen. According to them, she palpates something is abnormal. She thinks it's the liver, who is a little enlarged. But this is the blood work of Muna. Uh, as you can see, there's no big changes if it's in the middle. I don't know how many of you are familiar with this. Nothing really excited. There's a little bit of changes that talk about a possible dehydration. This is chemistry. What I don't like is essentially looking for protein, and my very red flag is albumin. Both are in the lower normal levels. Albumin is 2.4, still within normal limits, and I don't like the other one is cholesterol down because it's a mild marker of nutrition. In general, animals with who have absorption problems can have a level of lower cholesterol, but nothing really whoa, whoa, whoa. So those are the radiograph. I'm gonna give you a minute. Let me know if you think something. Along with this, in that time, what we use is looking into the cava vein to see if there's a severe dehydration or not. Today, we do the same, but with ultrasound. And we look for that to look for bulimia. In severe dehydrated or hypovolemia cases, we look to the abdominal cava vein, exactly in the point who go through the hepatic veins and get it into the chest. So we want to look into that. And the VD, nothing spectacular. The classic report of radiologists who talk about the spine or there's something that he found possibly, maybe, potentially, could be, there is some signs, etc., but nothing really, this is it. So nothing spectacular. So we stay with Muna, we keep it in the hospital. We keep it with IV fluids. We use, in this case, Ringer lactate, 30 mLs per kilo per hour for 5 hours, and then we reduce it to 10. We changed the metronidazole. Now we're going IV. We use loperamide in attempting to control it with the diarrhea, and we use the IV Hills wet food, 4 meals per day, frequent small meals. Nurses said that Muna is interested but not crazy about eating, so kind of like they force feed a little bit. So 48 hours later, Muna is not responding. She is still having 6 to 8 bouts of diarrhea. The diarrhea changed from large bowel, and now we see mixture. We have signs of small bowel because it's a large volume, very fluid, and have signs of large bowel too, like mucosity, blood, and urgency. So that's mean not only large bowel but small bowel both are upset. So we trying to increase the IV fluid therapy to compensate for the losses. Now we start having concerns about albumin, and even with all the fears, we start adding colloids. At that time, we use hetastarch, who is the only colloid that we're using in very small amounts. At that time, was a little more aggressive, 10 mLs per kilo. We repeat the blood work and we try to do a barium contrast to find out if there's any ulcers that could be behind this. Being a boxer, somebody talked about the possibility of ulcerative colitis, but I didn't explain why the dog was losing weight. So nothing spectacular. The transit was normal. We used liquid barium and he leave the stomach. The stomach has some degree of gastritis, but nothing serious. Radiologists say that the time, the position, and blah 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 were all normal and reach colon in a little faster time than they should be. PD, you can see it's everything contrasted, and the funny thing is, even still the stomach is painted. So Muna actively losing weight. The ultrasound shows severe enteritis. What is compatible? Oops, sorry. Is compatible with IBD. So thick intestinal walls, but still with normal layering. Discussions about what we can do because Muna is refusing to eat. We have concerns about the enteritis, so we decide to pass a gastric tube. So we do not depend on her. We discuss about the esophageal tube. Gastric was the sides. And why? Because somebody decided to perform biopsies, say without biopsies, and that is the right reason. Without biopsies of the intestine, we don't know what it is. So we took advantage of a mini laparotomy to just take biopsies and to place the gastric feeding tube. During this, the problem was the diarrhea become more often. Every time we feed Mona, the diarrhea increased volume and frequency. We do a couple of tests again. Now we test for TLI. We knew the first TLI was normal, so exogenous pancreas was normal. Somebody suggests that maybe this was pancreatic insufficiency, but TLI was normal. And now TLI is increased. If you have increased TLI, trypsin-like trypsin-like enzymes, that is a sign of severe non-nutrition. Severe undernutrition is the cause for that. CBL is now increased, so the pancreas is upset, and the folate, who is a marker of intestinal function, is really, really low. So this is now getting better. It's actually getting worse. So we decide to remove the tube, and we move to parenteral nutrition. We use a commercial formula. Just a few comments about that. Parenteral nutrition has to be very, very careful because it's highly contaminable. So you have a very rich fluid that you're gonna give IV. So you have to be that is very, very aseptic, very, very aseptic. So everybody with gloves, the area has to be isolated, clean it, prepare, etc. Okay. So we add complex B. Remember, complex B is produced in the intestine, and Muna continued losing weight. She's not responding, and again, parenteral nutrition is quite expensive too. One bag of this can probably be around $300. So money start having an issue. At that point, Mona has been at least 7 days in the hospital, and it's not getting better. So we get the biopsies while we get nutrition. The biopsies of the liver, nothing to add. Spleen, nothing to add. And intestine come back with histiocytic ulcerative enteritis, small intestine. And colon come back with IBD, lymphocytic, plasmacytic colitis. So now we understand we're dealing with two things. The histiocytic enteritis affect the small bowel, while the lymphocytic plasmacytic is affecting the colon. And this is a really bad luck. Treatment in general for the colon respond okay, but the treatment for the histiocytic is not really good. At this moment, Muna is receiving maropidan, omeprazole, sulfasalazine, prednisone, azathioprine, sucralfate, fresh frozen plasma, and still not responding. So this is the time for reevaluation. And reevaluation, in some moment, if you work in intensive care or critical care or a very busy hospital, you need to ask yourself if you are doing something good for your patient or not. And we stop in a moment. We have a little meeting doctor, a second meeting doctor say, hey, we are not doing anything good for Mona. Mona is crashing down, and everything we try is not getting better. We talked to the owners, who at that point was really, really upset and sad. Not upset with us, upset with the situation, money wise, emotions, everything was running tough. So this is the last test that we did with that. Again, the CBC now is showing not response from reticulocyte, no big changes. Neutrophils are high, who is classic from immune-mediated enteritis. Eosinopenia, probably by the medication. Remember, this is not only the clinical condition, but also all the medications and drugs that we're using. We're using a bunch of things. This poor dog is a walking pharmacy. And this is the most dramatic thing. My albumin now is 1.6 with a total protein in 4.6. We want to find, there are canine albumin, but it's $150 the bag, who is just 100 mLs. We could use human albumin, but at this point, again, you need to stop and ask yourself, okay, I treated. Is she going to get better? Or I just going to gain 24 hours because tomorrow she's going to be exactly in the same point. And that was my impression and my kind of like pushing for, you say, we need to stop. Muna is not having a good time and we need to stop. So euthanasia was on the table now. She keep losing weight. She keep having 5, 6 diarrhea episodes per day. In the last 3 days, there has been already 10. She has received all here IV fluids with normosols, colloids, albumin, maropitan, omeprazole, sucralfate, kaolin pectin, probiotics, cyclosporine, prednisone, sulfasalazine, amino acid. And here you go, Mona. I think it was a fair decision. We all agree, the clients too. And unfortunately, this was Mona at the time of euthanasia. And I have to say, everybody in the hospital have a little cry about it. You really love it. She was really, really lethargic, and we feel very sorry, but at the same time relief because she was not suffering anymore. So at the time of reviewing the case, we all decided what we did wrong, what we'd have done differently. And again, look for information about this, and you're gonna read that it's very rare. Mainly boxers are affected. It's genetically based, like many of these things. Is similar to certain form of Crohn's disease in humans, but has a very poor response to therapy. So unfortunately, everything that we did was fine, but it was a bad condition with poor response. That's the story of Muna. Still, I remember. I get a little sad when I remember. So again, I found the eyes of this is beautiful. This ape is wonderful. The ape of the forest. So I wanna Keep going. How you doing, guys? I hope you're enjoying this. Let me show you Chloe. Chloe is a female spayed Doberman, 9 years old, 28 kilos, beautiful, really nice, friendly, cooperative. She came up because was lethargic for a week. Nothing really changed. Eating normal, less energy. They went to the general part of the hospital. They say maybe a little bit dehydration. Everything was pretty boring. A little low systolic. The saturation of oxygen was normal. Everything looks like okay, kind of like teenagers say today. The same was for Chloe. Nothing really spectacular. So what we did with her, we did the physical exam. No severe conditions were found. She was quiet. She always was quiet. So she always was kind of very gentle, but not very alert. According to the owners, that's what she was. She was never a very happy, active dog. We put a catheter. We give a little bit of fluids. We start with normal salt, 20 mLs, a little bit buprenorphine, low dose, 0.2 mg per kilo sub-Q. And we got x-rays just to find out if anything, because again, one of the interns palpated something and say she found something in the abdomen. The resident agreed with that, and we took x-rays. And our classic base data, who is blood and urine, CDC, KMUA, gases, light. And because it's a Doberman, we run von Willebrand factor. I don't know how many of you are familiar with this. Von Willebrand is a coagulation factor who make the platelets adhere to each other. And Dobermans have a disease where that factor is lower than normal, so they tend to have some coagulation issues. So my only recommendation about think about that if you have a doggy who comes for a simple spay, run a factor, a von Willebrand factor is a numerical thing. It's going to give you a quantity number. If it's low, really, really talk to the owner. If the owner don't want to do it, tell them that there's a possibility of nonstop hemorrhage because that, again, is not very common, but Dobermans are the breed who present this more often. So what we found is a mild acidosis. The pH was 7 to 2 with a little low bicarbonate. That was, I don't like that because that's mean the body is not well perfused, it's not using the oxygen, or some areas are anaerobic. Gases and urine were normal. That made me a little more comfortable. No elevated CO2, no elevated or low oxygen. CBC, a mild anemia, hematocrit is 31%, sorry, with 4.4 millions of red cells. Kind of like, again, neutrophils were 80% of elevated leukocytes. I can't remember, I think we're in the 12,000. Elevated, but not crazy. And a mild elevation of ALT and bilirubin. The x-rays and thorax say no evident changes, and the abdomen come up with a possible free fluid. We all jump, and I don't know if you see it, but we all see this. Here, let me show you. We all saw a mass here. Who all thought, oh, this has to be spleen tumor and it looked like we were wrong. This was not a mass, it was something else. The radiologist said that it's not a mass, but there is suspicious that there's a little bit of fluid there. There is a loss of serosal detail. We keep saying until today, say there is a mass there. So the same here. Here is a less evident that there's a mass, but you can see that the cranial part of the abdomen have no gas around except the stomach, and that is the loss of serosal detail. That could be pancreatitis, peritonitis, free fluid, etc., etc. But the radiographs were not normal. We talked with the owner. We discussed about ultrasound or tomography to further that. Client have financial restriction. That is a common situation now. So she declined the ultrasound and other tests. She keeps saying, yeah, but my dog don't look sick, right? And we have to say, yes. I mean, Chloe do not look that sick. So in this case, we decided to send her home. Now we use AD because it's a recovery diet that we use to increase the the amount of calories ingested, and with a very, very palatable. The dogs really like the taste of that. We monitor water intake and monitor if they're vomiting and diarrhea, just the case. But then the client called back and said, you know what, do the ultrasound. And say, well, cool. We send the ultrasound, and this is what we see in the liver. Definitely, this is not okay. Chloe has something here, and when we look this is what we see. That's the liver, and there's a mass around, and that's another mass, and there's nodules and masses everywhere. Keep looking into that. That is not the gallbladder. The gallbladder is the one in the back. Those are nodules and masses all over. The largest measure like 3.5 centimeters. The smallest like 1 centimeter, but there are multiple. So with this, we all look at each other like, hey, we're about to send this guy home. Wow. So there's no clear origin. It, according to everybody, it seems to be based on the liver, not on the spleen. But there's no clear picture that say that the spleen is not involved in the same situation, because there's multiple masses. The only ones who do not seem to be affected seems to be the kidneys and the bladder. Everything else has some nodular presence. Definitely the lymph node, the mesenteric lymph nodes were also upset. And we discuss again with the owner, money wise, what is the most important thing. She keeps saying what it means. This very likely this is a form of cancer. Obviously, she cannot afford to do tomography or the exploratory. Biopsies is also so. We finally agree to move on with a fine needle aspiration. So put a needle there directly with the ultrasound, get some cells, and produce cytology smears. And that was agreed because it was the less expensive, was still was $500. But compared with everything else, who was $1,000, she agreed with that. The final diagnosis was carcinomatosis, a pretty bad carcinoma. When you have carcinomatosis, in very, very rare cases, you know what was the primary tumor. But what you see is all metastasis disease in the whole abdomen. We don't know which one. This was peritoneal. The only way to find that exactly is biopsies. Obviously, decline, and a request the euthanasia. And Chloe was euthanized. So what we learned about this, we were about to send this dog home because dogs can have these severe cancers and almost pretty no symptoms. If we miss the ultrasound, she will be at home dying. So please remember that dogs and cats can be very sick without a bunch of severe clinical symptoms. So keep that in mind, okay? That is, again, the National Geographic. Let me see how we are on times. We still have a little more times. Turn your speakers down if they're on. I'm not on. They don't have much. So I know there's some variation. Okay, let me show you Lily. This is a short case. Lily, obviously, is a cat. It's a female, 11 years old, domestic long hair. Lily was diagnosed by me, I remember that, by asthma long time ago. It was referred for evaluation, and the asthma was diagnosed and treated with prednisolone, 1 mg per kilo once a day or every other day. Lily, I normally talk about this with clients when I talk about asthma. Asthma is a chronic situation, it's not acute. Even if you see acute crisis, you're going to live with asthma, and your cat too. So remember, she's going to have crisis that we need to bring. I normally, for crisis, I recommend inhalers. And the drug that we use the most is fluticasone, who is a very rapid, powerful steroid and again, inhalers. But she come back in a crisis, a respiratory crisis, and a stupid me, we all look and say, it has to be an asthma crisis. We talk about this. But the client also complained that Lily is limping with both hands. So both front hands who was sleeping. So that was different. So we give a little bit of oxygen, sedatives, blah blah. The same approach to try to figure it out what to do. Uh, Ultrasound in these cases do not provide a lot of information. We prefer X-rays. That's why we sedate, put it with oxygen, prepare everything, and we take chest radiograph in 30 seconds. If the cat is fighting or stressed out, we do not take the X-ray. So when we examine the fingers on the toes, it's very, very painful. They're swollen. There are no visible wounds. We talk about possible getting trapped in some door or gate or somebody step on this. So say, hey, she may have some fractures here. So we're gonna do some X-rays of also the hands. We're gonna do the chest and hands. And the client approved. So this is the chest. Always another message: take both views because in this one is suspicious. This right is, I think this is the right one. This is the left one. Almost look like a different cat, but you can see in this view something that you can in the other one. There is clearly a mass there who is deviating the chest. I mean the cardiac shape and the bronchi. So we took the X-rays, and well, what we found is this severe osteomyelitis or osteolysis of the phalangeal, the third phalangeals, and in some cases the second, who's kind of weird. We thought about possibility of infections, osteomyelitis, etc., etc. The cat was not a dew clog who can sometimes lead to injection. And of course, one of the residents at that time said, "Hey, I read about this. This is called long digit syndrome." And we all learned that day. This was a couple of years ago. The feline long digit syndrome, who is a very uncommon metastatic pattern of primary lung tumors. So what she had was a tumor in the chest, and some cats tend to have a severe osteomyelitis, I mean osteolysis, due to metastasis of the lung tumor in the digits. And he produced a very, I know they changed the name of this. There's a new name for this. I don't remember. Pachi Clemente always talked to me about this, and Pachi yelled at me, "This is not the name. The name is," and I can't remember. I think it's a carcinoma. There's a secondary name. But think about it, guys. If you have a cat who have a lung tumor and can have pain on the foot, think about this syndrome. It's not very common. I see 2 cats in my life with this. So that's another thing. Okay, check it out. This beautiful. Those are emperor penguins in Antarctica. That's the good things. There are no polar bears in Antarctica, so these penguins have no major predators except seals, leopard seals. Okay, Ramba. Uh, Ramba is a feline cat, domestic short hair, 4 years old, 4 kilos. Uh, she was run over apparently a car an hour ago. No witness. She come back with impaired consciousness. She's not really awake. There's clear symptoms of head trauma. There's ocular hemorrhage, as you see. The jaw is fractured. There's shallow and rapid breathing, oral bleeding. There's blood coming from the mouth and nose, as you can see there. Systolic pressure is really low, 85. Remember, cats are not dogs. So most of the time they show up in the ER with hypotension. They do not display the acute phase of the shock. You normally miss that in cats. And the saturation is already low at 89%. So Ramba, definitely a major trauma. We check ABC, airway, breathing, circulation, and D stand for disability. We start with oxygen. We put a catheter. We start with normal salt, lukewarm. I want to rise the temperature. Buprenorphine for pain management. We took thoracic and spinal X-rays and ran our test. She was very depressed, so she didn't need any sedatives. So keep an eye on that. Analgesia always, sedatives as needed. Uh, Again, she have consciousness compromise, quite alert. partially responsive. The mandible fracture is very clear. There's some teeth loss. There's a periocular hematoma, a hemorrhage, pulmonary contusion, and probably pneumothorax. We have a lot of concerns about this. We see urine, and the urine looks normal. We run urine and blood, nothing really spectacular, but now we have a database. This is a common question that people ask: why you take blood if it just happened? Nothing is going to be different. You don't know. If you don't have a primary database at the beginning, you don't know if the changes after that are big or small because you don't have a database to compare with. So always have a basic database. If you have a hematocrit on this database of 36, then you take a new sample 6 hours later and it's 28. Oh, now you have to compare. Okay. He was a mild acidosis with a low bicarbonate. So everything was perfect. Checked the hemorrhage in the eye. There were some concerns about if that eye will survive. Fracture possible in the nose. And during this process of trying to make it stable, Ramba goes in respiratory arrest. She stopped breathing, all the alarms ready. So remember, if you have a cat or a dog with cranial trauma, the real name today is TBI or traumatic brain injury, trauma of the head can lead to apnea or respiratory arrest. The origin is central. The respiratory valve goes inside, most of the time because an increase in the intracranial pressure. So remember, also these cats tend to have bradycardia. So if you have a cat, we have cranial trauma, brain trauma, or signs of that, like bleeding in the eyes, fractures, jaw, be ready to intubate because this cat can stop breathing at any time. And if you are not ready to intubate, you're going to lose very valuable time try to find the endotracheal tube, the laryngoscopy, etc., etc. You need to be ready because it's time against death. Okay. So as she stopped breathing, you don't have to treat anything else except start with CPR. This is the modified Glasgow Coma scale. Scale is modified because it came from humans, and in humans there are some responses necessary, like what day is today, what is your name, how many fingers, etc. This go from 6 to 1. 6 is almost normal. 1 is very, very abnormal. And they evaluate these three things: how awake he is, motor activity, if he can walk, and brainstem reflexes, who essentially are pupillary and oculocephalic reflexes. And evaluate. It's simple, it's fast. The whole idea is when you have higher values, you have a mild TBI. And when you have severe TBI, you have lower values. Uh, the impressive thing about this is dogs and cats can survive much, much better than humans at the same level of Glasgow's. So Glasgow with moderate TBIs still have some very decent amount of mortality. Dogs and cats almost no. The general mortality is less than 10% in dogs and cats. Humans, whoa, don't want to talk to you. So we have to start CPR. Ramba's dying. We normally start with this. The classic question is, we have to start with ABC or CAB. We start with compressions or with A. In this case, I decide ABE because the cat is not breathing. So we need to get control over the airway and start ventilation. We normally start with PPV, who is positive pressure ventilation, normally around 5 to 10 centimeters of water. Do not overventilate, not in frequency, not in pressure. A lot of people overcompress the ambu bags, and that produce barotrauma. And in cats, barotrauma could be fatal. So be very conscious what is the volume of a cat. A cat can have 8 to 12 mLs per kilo. So this cat is 4 kilos. He can have 30 to 40 mLs. If the ambu bag is 1.5 liters, and you push the whole 1.5 liter, you're gonna blow the lungs of this pure cat because he doesn't have the space for that amount of volume. So be very gentle, okay? If you don't know how much it is, look the chest. The chest should deform no more than 1/3, okay? We don't know what is the current situation. And if you don't know about how to go on CPR, remember, you cannot learn how to do CPR looking for TV shows, even if they look like they know, they don't. And in anybody who knows about medicine can realize how stupid comments these guys do when they're trying to show you. And in some cases, this could be very dramatic if you try to use extreme moves to do CPR, because it do not work this way. Okay, I always remember that girl. I don't know. You probably see this in Europe too. Here was a big success a few years ago. I never understood that girl because she always looked to me like she was constipated. Like, I don't really want to be a vampire. I don't like blood. So I don't know why she picked her for vampire role. So if you want to learn about CPR, there is a whole new bunch of information. Google this recovery initiative. This was a campaign on 74 areas of veterinary medicine intended to decide what is the best way to do it, what needs to be done. And the better of everything is published in the Journal of Veterinary Emergency and Critical Care Society in 2012, and is free access. There's 101 recommendation and guides what to do and how to do it. Also, there is a certification system that you can get online. Okay, so read about it. There's a lot of things. This is the real thing, how to do it and why you have to do it that way. On this case, you need to have control about basic support, who is control of the airway and the breathing. That is the most common thing to do. And the third part about basic support is compressions. If you are alone, it's very unlikely that you're going to succeed on CPR. If you are not alone and you have everything, so people, oxygen, tubes, machines, monitors, etc., your best option of success is around 20%. If you don't have everything, your success rate is going to be between 4 and 6%. So you are really, really playing against a very large amount of odds, because you're playing God. You're trying to pull back an animal who's dead back to life. So again, don't feel frustrated. And if you're alone, concentrate on compressions. Compressions are more priority. If you have another people with you, so you have a two resuscitation team, one have to control this and ventilate, and the other one has to do compressions. Compressions are the most critical part of the CPR. And because that, I'm gonna give you some recommendations that I put together in something called the honeymoon law about thoracic compressions. What it means this, and the honeymoon law when you do compression is push hard, push quick, or push fast. Do not stop. Assume the right position. If you stop, let me know. If you have to stop, please be sure that you have somebody to replace you. And I'm gonna be sure that that is not valid for the honeymoon. It's only valid for RCP. So remember that: push hard, push fast, don't stop. This is a very common cause of dying during the CPR. People do 1, 2, 3, 4, and they stop. 1, 2, 3, 4, 5, 5. They give it for 10 seconds and they stop to look at it. You do not stop for at least 2 minutes, and you give 100 compressions per minute, and you ventilate without stopping the compressions. Okay, so gain control of the airway, give ventilation 6 per minute, and give compressions 100 per minute. Do not stop. Okay, so CPR is a whole lecture, so that's not the point of this. What a beautiful photo. Again, National Geographic. So I think we're almost pretty much on the final part. Sorry, I'm receiving messages from the bosses here. Okay, we have like 10 minutes more. Okay, let me show you Tumbleleaf. Tumbleleaf is a female domestic medium hair update. And he started showing this. That's clear scissors. People in general paralyzed with scissors have this horrible feeling that the dog or the cat is possessed by demons. That's why it's this. That's actually why they killed so many people during the medieval times, because they thought it was possessed by evil. So no history of epilepsy, no serious trauma. This is the first time. Owners are really, really emotionally invested. They don't know what's going on. So arrive after the ictus to the hospital. We give sedation, midazolam 0.2 mg per kilo sub-Q. We put an IV line. We start fluids, 20 mLs per hour, who for that size of cat is very small amount. It's like 40 mLs per kilo per hour. We give butorphanol as a sedative. We put in an oxygen cage at 3 liters per minute with a VO2 of 50. And seizures continue to be one and the other one. So we start with phenobarbital IV at 8 milligrams per kilo to try to control this. Tom Leaf has occasional seizure for another 24 hours. During the crisis, we use propofol. We normally start at 4 mg per kilo of propofol, but most of the time that's not enough, and we have to use all the way up to 8 milligrams per kilogram. In general, what we use is titrate the amount to effect. So we give propofol until he stops. Remember, the only side effect of propofol that you should be scared about it is respiratory arrest. I see patients, I kill patients with propofol, so please be aware of that. If you see respiratory depression, do not use propofol in large dosage, okay? So uh, later that day, after we readily have the control that, we start seeing respiratory distress, and we start seeing this drooling coming out of the mouth. But the respiratory distress start crescendo and start getting more complicated. We increase the amount of oxygen and we try to figure out what's going on. Give it a look. Rapid, a little abdominal, big cat, American model. He used the abdomen to breathe. This is not a normal respiration. But check the nose. Is not seriously depressed, but that respiration is not normal. So we try to figure out what, and this is what we found. Tumble leaf, this is what we found. So we rise the temperature, the oxygen, uh, very much up, and we get blood gases within normal limits. So we suggest that, and we investigate, and this is what we found 6 hours later. Remember something, and this is probably the best lessons that Tumbleleaf teach to us. Cats and dogs with seizures can develop neurogenic pulmonary edema, and that can be a consequence that you do not expect. Okay, so remember to be ready. After seizures, they can present a very acute pulmonary edema who is not cardiogenic. Okay, the treatment for neurogenic pulmonary edema is similar. You use furosemide, you give oxygen, you can use some vasodilators like hydroglycine. But my whole point is think about it, because nobody thinks which you are so concentrated on the seizures that you forget about the possibility of this. Okay, beautiful kitties, big kitties. I think we're pretty much done, guys. Blitz. This is going to be the last one, okay? Blitz is a beautiful male neuter, huge cat, long hair, 2 years old, up to date with all the vaccines, eating dry food, is indoor, the only pet. But since yesterday, he's showing symptoms to be weird. This is the classic cat that the owner say, something is going on. I don't know what, but this is not my cat. He's depressed, anorexic, he's vocalizing and vomiting. He's not sure if the cat is using the litter box, who is a common story, big, obese, large male cats. think about possibility of block. In the physical exam, he's quiet, partially alert. There's a diffuse abdominal pain, mild dehydration, and the urinary bladder is mildly distended, painful, and cannot be expressed. Blitz made very clear that he would not tolerate you squeezing the bladder. So we start with the management. We put IV fluids, ringer lactate. Your main enemy on blood cats is pain and hyperkalemia. Also can have severe azotemia, but what killed the cat is the potassium. So we start with buprenorphine. We need to treat. We use a dosage, high dosage of buprenorphine. We use meloxicam too as an anti-inflammatory, and we start running tests. And we run an ultrasound. This is the classic view of a big bladder. You can see the urethra and these things. This is the urethra. Most of the time when you see this hyperechoic thing is because you have a plug there. Who is the cause more common of block in male cats? So we confirm he behaves and act like a blocking cat, and we start doing that. There's a lot of changes what to do with these animals. Uh, we used to be very aggressive. We try to be a little less aggressive now. We know that the block is a consequence. It's not a primary problem. There's so many factors involved in this that today is known as the Pandora syndrome. We know that even the microbiome in the intestine has something to say about this with bleeds. So we try to gain control about the pain, the uncomfortable feeling, and the electrolytes, the abnormalities, and the dehydration. Most of these cats are with kidney failure, not because the kidneys are responsible, because they cannot fight against the pressure inside the bladder, so kidneys are not working. So classic exam, azotemia, acidosis, anemia, the BUN is 140, creatinine is 9.9, super high, phosphorus is high and 8, and potassium is 8.7, albumin and globulin high most of the time because it's dehydrated, pH is 6.95, freaking acidotic, and the hematocrit is 18. That was like, why is he so anemic? What normally do in this is cysto, we try to relieve pressure. If you don't relieve the pressure, you're gonna have a really hard time passing the urinary catheter to decompress. So we decompress through putting a needle as close as the bladder neck as possible, and with an extension line and a three-way lock, we remove as much as fluid. If you use the ultrasound, you can do this way more safe. One of the factors who has been investigated about prognosis is how dark is the urine. The darker the urine, the worse is the prognosis, okay? So, but we know much better about this now, so we save more cats with this. So we place a catheter there. There's a little pornography photo here. We give propofol to pass the catheter, where it's a Tomcat 20G. And what we did is something that today is questionable. We watch the bladder and we use lukewarm ringer lactate fluid. Today, there's a lot of discussion if this needs to be done, if you have to do it with saline. The last research said there's no difference on washing or no washing the bladder. So I put it on the table. Some people say that they want a flash because they want to remove all the debris that can produce a new block later. We attach the catheter, we put some sutures there around the penis, and we fix this. We attach that to a line because we need to know what is the production of urine. So we measure, we empty a bag, and we start counting how many mLs of urine this cat is producing. Most of these cats produce way more than the classic 2 or 3 mLs per kilo per hour. They normally produce 7 to 10. We repeat the exam 4 hours later after the block, and everything seems to be getting better. The BUN goes down, the creatinine goes down, phosphorus goes down, potassium goes down. We're really good. However, something was not okay, and the hematocrit goes down too. from 18 to 14. And everybody start freaking out. And I have to raise my hand and say, hey guys, remember something. Cats with severe blocks bleed, and a lot of the blood produce anemia. And this is a work published quite some time ago in 2016 by Dr. Drobats and Santoro, who proved that anemia is very common in cats with block. And it seems like all that blood goes into the bladder and is drained into the urine. That's why the anemia is a factor on these animals. So everything was fine. Blitz was a happy case. 24 hours later, we keep it under control. Meloxicam, again, another point. There are questions about if NSAIDs like meloxicam are beneficial or not to send home. There's not a lot of strong evidence about it. I like it because I think it produces a certain degree of analgesia, and the combination of meloxicam and buprenorphine seems to work very nice well. However, it seems that they do not interfere with relapsing. Still, cats with all this medication, etc., have a 40-60% of chances to relapse. And the relapsing seems to be related to other things like stress, diet, and microbiome dysfunction. I'm telling you, again, all the new knowledge only said that whatever we were doing last year is wrong. So we sent it home with lactulose, clindamycin suspension, classic treatment to go home, pain medication, antibiotics. Again, this is also question, very question. Almost no cat, and this was a large study, and I can't remember, I think it was Pennsylvania. Almost no cat who suffered block proved to have bacterial contamination in the urine. It looked like the urine is very aggressive, even all the blood, etc. So infection was not a factor on that. So I know everybody is still going to send antibiotics, is imbricated in the DNA, but just remember this: infections are not a part of the equation. If you're going to think about it, send some sample for culture. The majority, the large majority of those cultures come back negative. So later that day, so 48 hours later, the owner calls. He thinks that the cat is diabetic because he's drinking water like crazy and he urinates 12, 15 times per day. So he want to know if that is cool. And you have to look and say, hey, sorry, we forgot to tell you, but there is a very large amount of polyuria and polydipsia after you relieve the urethral obstruction. So this is a common side effect. So cats, when you send home, there is a kidney issue. It's gonna long to explain, but it has to do with the concentration inside the medulla. These cats drink and pee a lot when you decompress, and that takes around 7 to 10 days to get back to normal. So do not step into that and don't tell the client, oh yeah, he's diabetic too. Okay, so I'm gonna show you this, and I think I'm gonna share this with you. This image, this beautiful photo can teach us two things from this photo. The first thing is, for some individuals, sex seems to be more important than food. And the second one is watching porn can kill you. So be aware of that. Perfect. Thank you so much, everybody. I hope you like it. I finished exactly in time, and I'm so sharp. So I'm gonna get out of this, and I'm gonna come back to my platform.
Yes, Dr. Tello, thank you very much. Can you hear me?
I can hear you perfectly fine. Thank you.
I've really enjoyed your lecture. I think both of us. Let me just first introduce myself. My name is Frane Jakšić. I am in charge of marketing for DDL Zagreb, and my colleague Mihaela here. Should we go right to the questions?
Please. Again, I want to thank you guys for supporting this education thing in those weird times in the whole world. Virtual education has become some very important things for professionals. So companies like yours supporting this is really helping the veterinary medicine to remain in contact with knowledge. So thank you so much for that.
Yes, definitely. And thank you for joining us. Okay, Michaela?
We wrote the question so we can start. You don't have to read it. I have it on the paper, so it should be easier. Do you have any comments on using vitamin K on traumatized patients? Is there a scenario where you would not use it?
No, I mean, I don't think in general vitamin K is overrated. uh, Only when there's deficit, and pretty much the only deficit we know is certain type of rat poison who sequestered that. Also, some individual has low levels of vitamin K. I have no problem using it or not using it. So if they want to use it and feel comfortable, go for it.
Thank you. The second question, what do you think that caused the tracheal rupture in that cat, the case you showed us?
I'm sorry, what rupture or what?
What do you think that was the case, that tracheal rupture?
Oh, I think was the two. What the most common thing is we overinflate the cuff on the endotracheal tube. That is the most common case. That is my impression. We discussed with the technician who intubated the cat. She had a lot of experience. She has intubated. The size of the tube was normal. So we come up with the conclusion that the cat may have a little more smaller trachea than a cat of that size, but we couldn't prove it. Lucia was gone.
Thank you. When you were representing us the Muna case, was leptospirosis investigated as a cause?
No.
No.
No, we didn't think about it, and no, we have a lot of lepto here, and because we have so much water in Oregon area, there's hundreds and hundreds of lakes, lagoons, ponds, etc., everywhere. So we see a lot of lepto, and lepto is very familiar for us. And no, that was not part of my differentials. We what have seen. I mean, when you look into research, the first presentation of lepto is kidney dysfunction and secondary liver dysfunction. So you normally see animals who are depressed, lethargic, azootemic, and secondary they have elevated liver enzymes, etc. And we are very rapid doing tests for that. So we normally test rapidly for antibodies and much rapidly for PCR. Okay. So yeah, sorry, I didn't think about it, and I do not connect what was happening with her with the possibility of leptospirosis.
Okay, thank you. The next question, how many emergency patients do you have per day, and how many of them stay for several days on treatment? And how many days are there in average?
I mean, I think we have an average of 15 cases per day OER, and a third of them remain in the hospital. So I would say 5 per day has to stay in the hospital for hospitalization, ICU, further
Can you
care,
estimate
etc.
on how many days in average they stay in the hospital?
Say that again. How many days? I would say 3 is an average. We have some. Yesterday, I have one. She come up and she thought it was a wound that. It's a funny story. She come up with a wound on the flank, and she thought it was the groomer who cut the dog with the clipper. So we sedated, we put it on, and we realized it was actually not the groomer, not a wound. It was an open tumor. It was a small tumor who blast. So we have to change the whole thing from treating a wound to talking with the surgeon, and that dog is in surgery today to remove that and send a biopsy. So that stay for 24 hours. But also, I have another cat who came for a possible asthma, who ended up having a polyp in the nose that we're going to be treating for at least 48 hours. So it's very, very variable. But I would say as an average, we keep it 5, and they normally stay 3 days. It's expensive. And finances are taking a hit now with all this of the pandemic and COVID. So a lot of people say, sorry, I cannot afford. So a lot of people decide to take it home and come back the next day. So we see that a lot.
Yeah. Okay.
Thank you. The second question is, are you not afraid of the rupturing distended bladder in blocked cat?
That was a very common problem. If you do it, yes, but if you do it with care and with a guide of the ultrasound, it's very unlikely. If you do it, with care, the cat is sedated, not moving, and you guide your needle and you know how to direct your needle. And second, even if you break the bladder, it still is indicated. You can go later to remove. What you want is the kidneys be able to depress the pressure and start working again. So can happen, yes. There are some cases reported about laceration. In my experience, I see that I could say, I don't know, 5 times, and always has been when it's moving, going into the needle, and the cat moves. So you have a wrong movement. So that's why sedate your cat and be sure that it's not gonna move when you go in.
When we're on that topic, the next question is, how long after obstruction do you leave the catheter inserted?
Most of the time, 24 hours. There is a very gray area. You try to remove it, the soon the better, because it produces stenosis, irritate the urethra. The more time it stay, the more irritation produced. But also, you don't want to do it too early that the cat is going to reblock and you have to catheterize again. I would say in average, we start considering that after 24 hours. But we have cats that we remove it immediately after 24 hours, and we have another cats we keep it there because they have an enormous amount of sediment for 48, 72 hours.
Thank you. We're still on that topic, and the question is, what is your experience with recurrent blocked male intact cats? Do you have any advice for management except for diet and stress reduction? Would you consider deslorine for chemical castration?
Oof. Okay. A male neuter obese cat is the main victim of this condition. It's the most common patient that you're going to see in your hospital. When the cat is blocked, he has 6 times more chances to reblock in the future. A male the question is non neuter, so intact.
With intact male, yes.
Intact, so no neuter. Those guys are as possible as female, very rarely. When you have one, it's not the neutering what you want, is the space on the urethra. When we have those cases, we instead of neutering, one of the things we recommend is the perineal urethrostomy. We turn those males into females. We open the urethra to provide no stenotic parts. I don't know if I answer. I don't use chemical castration here. There is some push to use it, but there are some concerns about suffering, and Americans are very, very, very sensitive about the possibility of suffering, and you can get in trouble. And trouble means lawyers, and lawyers means money, and I don't want to spend money on lawyers.
Yeah, I agree. As I see, there is no more question in the chat box, so I would like to thank you very, very much on this lecture. It was excellent, and many attendees said in our chat box that it was great. So thank you very much.
Thank you so much for having me, guys. I'm liking that you say. Thank you, both of you, for helping me out. Thank you for all the help with this new platform, and I'm really glad that you guys enjoyed this. Have a good night.
You too. You have a good day.
Yeah.
Okay, so for everybody who is still sticking around, we're going to go to the quiz now. Let me just share the screen. So if you haven't already, please click on the link in the top of your screen. And we should be getting going soon. Okay. So we have 142 people in the quiz. So we're going to start. You will have this time only 20 seconds to answer the question, because the questions are a bit shorter and the answers are a bit shorter. So, just keep it as fast and as correct as possible. So here we go.
The first question is, a good alternative for analgesia in trauma cats would be azapromazine, tramadol, buprenorphine, dexdomitor.
Okay. 5 seconds to go. 3, 3, 2, 1. And the time is up. Okay. Only a couple of wrong answers. Let's see who's leading for now. KK with 85 points and Anna matching with 85 points again. Last time we had 2 winners, so let's see what happens this time. Let's go to the second question.
The measuring lactate allowed the clinician to evaluate ventilatory performance, cellular perfusion, mentation status, central venous pressure.
Okay, a lot of quick answers coming in. 10 seconds to go. I think not everybody had the time to answer. Okay, so the correct answer is cellular perfusion. It was split with ventilatory performance. Okay, so let's see the results now. Anna is still leading with Nina K following with the same amount of points. Oh no, Anna took the lead. KK was leading on the first question. So let's go to the third one.
Chocolate is a toxin. Interfere with hemoglobin situation, produce severe hypertension, have a little dose of 1 milligram per kilogram of weight, and lead to severe arrhythmias.
Okay, this is a tough one. Okay, and the correct answer is lead to severe arrhythmias, and a vast majority answered correctly. Let's see the results. Oh, Anna is blowing away a little bit with 9 points difference ahead of Anya. Number 3 is Pio01. I guess that's the pronunciation. Let's go to the next question.
The fourth question, about tracheal rupture in cats. Is it correct to say some ruptures are spontaneous? The anatomy of the trachea in the cat predispone to trauma. The area of rupture is often behind the laryngeal entrance, and cats develop pneumomediastinum before emphysema.
Okay, the time is up. Ooh, this one is quite split. 35 answers correct. Some ruptures are spontaneous, and 34 answers for cats develop
Pneumomediastinum.
Yeah. Okay, let's see the results. Oh, Pio taking the lead. KG second place. Urška Škulca is in third place. Okay, it's getting close. The last question.
Injury, is it incorrect to say the prognosis in dogs and cats is better than in humans? The usage of steroid decreases the mortality in severe cases. The higher score in the Glasgow scale is linked to the higher mortalities, and subdural hemorrhages can lead to respiratory arrest.
Okay, and the correct answer is C. The higher score in the Glasgow scale is linked to higher mortalities. And let's see who the winner or winners are. Oh, KG has taken it in the last question. So congratulations to KG. Please leave us your information in the chat. Thank you to all the other participants. And we can only ask you to join us in our next webinar, which is coming up next week on Wednesday, on the 28th. Same time, same place. Thank you all for attending. Mr. KG, again, let us know how we can reach you. Send us a private message or leave your email address in the chat. And to the rest of you, have a great night. Thank you for being with us.
Thank you. Good night.
Cijenjeni partneri i sudionici, drage kolegice i kolege Slovenije, Srbije i Hrvatske, i ovo naše drugo predavanje uspješno je završilo. Hvala vam što ste uz nas, hvala vam što ste svojim sudjelovanjem omogućili da Adria Team još jednom za vas kreira još jednu fantastičnu dodanu vrijednost. Za kraj pozivam vas na naš sljedeći webinar koji će se održati 28.10. u 8 sati. Hvala i želim vam ugodnu večer.